Okay, we are recording now, and all right, we shall start. Thank you everyone for being so punctual. I'd like to welcome Professor Sarah RODDY, a pediatric neurologist all the way from Loma Linda University in the US. So we've been all focused on lungs and, other technological things in the NICU for a lot of our talks. This is something very different. Sarah is an expert in the developmental and neurological consequences of adverse childhood experiences, something we don't consider when we are trying to resuscitate and keep alive our babies in the NICU. So without further ado, I shall pass you on to Sarah, but just before we start, this session is being recorded. I'll show it to Sarah before I distribute it to make sure no one's doing anything really weird in the background. As you all know, our WhatsApp group and possibly our emails were hacked a couple of weeks ago, so we're trying to get on board with our WhatsApp and WeChat advertising. But if any of you on the audience would like to join our WhatsApp groups, just send me a quick message and I'll put you on. It's super secure now, and I promise you, we will not get hacked again. So, ready, Sarah?
I'm ready.
Okay, cool. So I shall stop sharing and the floor's yours. Thank you.
Okay, let me see now if I can share my screen again.
Lovely. Got it.
Okay. So we are going to review the developmental and neurologic outcomes from adverse childhood experiences. And there's been a lot of interest in the pediatric population about what their health risks are after ACEs. But I thought, well, it'd be kind of nice to look at what happens developmentally and neurologically. So from the 1950s to the 1980s, the brain was considered to be immune to the effects of stress. And then the next 2 decades, it became apparent that there were probably persistent cellular consequences of adversity that would persist even into adulthood. And over the past decade, there's been interest in what is happening in the brain as far as the maturation of brain circuits, synaptic pruning, and what can happen to the brain from the chronic stress. So the term adverse childhood experiences actually came from a study that was published by Dr. Folletti in 1998 in the American Journal of Preventive Medicine. And he was operating an obesity clinic in San Diego. He worked at Kaiser Permanente, which is a big health care facility. And so they had a lot of patients, and as he was seeing the obesity patients, he had this lady that came in that weighed over 400 pounds. And she was placed in their weight reduction program and lost 132 pounds in the first year and was very pleased with how she was doing. And then she suddenly started gaining weight back, actually gained 40 pounds in 3 weeks. And so they saw her for follow-up and asked her what she thought was happening. And she mentioned that she was sleep eating. She, as a child, had been sleepwalking, and this started again, and she would eat at night when she was sleepwalking. And they questioned her more. And it turned out that she had been propositioned by an older married man at work after she had lost all this weight. And so subconsciously, she was probably starting to gain weight back, and they talked to her more about this. And it turned out she had been sexually abused from age 10 by her grandfather. So they thought, well, this is a very interesting case. But then a short time later, there was a second person with a similar story. So they thought maybe we should start asking about this. And So over the next about 250 patients they saw, they asked, and over half of them had been sexually abused. They also found other adversity that these patients had suffered. They presented their findings in an obesity conference in Atlanta, and it was not well received. People thought it was kind of crazy, and they suggested that if there was someone there from the CDC, the Centers for Disease Control for the US, and they said, if you want to really find out if this is related, you need to do a very large study. And so since they had this large clinic with over 13,000 patients, they sent questionnaires to them, and they, of course, they had their health records. And so then they matched their questionnaires about adversity with the health outcomes. And they found that those who had experienced a variety of forms of maltreatment in childhood, neglect, or that we'll go over what the things that they included, they found that there was an effect on health, a 12-fold increase in people who'd had 4 more categories of childhood adversity, and they had a 12-fold increase in alcoholism, drug use, depression, suicide, 2 to 4 increase in smoking and sexually transmitted disease. And there was also a relationship to other adult health problems. There were limitations though in this study. It didn't include what happened to the children. It only looked at adults. It also it only looked at these 10 categories, and we now know that there are other dimensions of childhood adversity that were not included, and we realized they can also have an impact on the child's development and future adult health issues. They looked at deficits, but they did not include assets that might mitigate the adverse experience. And so over the last 20 years, the research into adverse childhood experiences has expanded to include some of these areas. Looking at childhood adverse experience, there's commission where somebody's actually, excuse me, perpetrating the experience. So that includes physical abuse, sexual abuse, and emotional abuse. It can also be omission with them not getting the things they need. So there can be physical neglect or emotional neglect. The 10 things that have been traditionally included in childhood adverse experiences are the abuse and neglect that we talked about, but also the household challenges. So having a parent with mental illness, if there's domestic violence, divorce, if a parent is incarcerated, or there's substance abuse, all of those can have effects on the child's development. There are other things that we now recognize, including poverty, malnutrition, the effects from being in a war, terrorism attack, those kinds of things also are known to have negative impacts on children. And the World Health Organization has now developed an international ACE questionnaire that includes a lot of these newer things that have been recognized. There are also things that haven't been as well studied that are real, we realize now have an impact. And one of the most recent things that has been noted is the sensitivity that a parent has to their child. So the vocalizations, touching, how they respond to the child. And if there is inconsistency in the way the parent responds to the child, they actually saw changes in cognitive development at age 2 and memory at age 7. So there are probably a lot of more subtle things that we're just becoming aware of that also are not the typical things that we think of when we think of adverse childhood experiences, but they are things that are having a negative impact on children. it's a huge problem. The WHO estimates that 1 in 5 women and 1 in 13 men worldwide have been sexually abused during childhood. There's a survey that's done in the US, and the survey found that about 1/3 of the US population, or 2/3, have been exposed to 1 or more ACEs, and 16% had 4 or more. So often one form of abuse goes along with another one. And they're estimated that 15 million children in the US are witnesses to domestic violence annually. So this is a huge problem. As child neurologists, we're seeing children with disabilities, and so the population of children that we see has a risk of suffering ACEs more even than the general pediatric population. Neglect is the most common form of maltreatment in these children, just like in the general pediatric population. And children who have behavioral disorders are at the greatest risk for all types of maltreatment. And I guess that's not surprising. It's more likely that a parent's probably going to physically abuse a child if they've got a behavioral disorder and they're having trouble dealing with it. And children with autism are at a particularly high risk of suffering bullying. Parents often struggle with their marriage when they're taking care of a child that has autism or other disabilities. And so these children can have that as one of the ACE experiences. ACEs are stressful events, and just looking at stress and how it can impact the brain and development, it's actually divided into different levels of stress. So positive stress is actually considered to be something that can be a good thing because you learn to adapt to it, and it makes you much more able to deal with things as they come in life. So positive stress is a moderate, short-lived thing that's a normal part of life. So this is the child who goes to daycare, and so they have to adjust to going there, but it's going to be stressful at first. Or they're afraid of an animal, and so they have to learn that it's okay. So that is a normal part of development, and it teaches the child to be able to adjust to these. Tolerable stress is stress that has the potential to negatively affect the brain, but if there's an adult that can help support the child through it, then often that mitigates the potentially harmful effects. And so an example of that would be if a parent has a severe illness and the child is stressed from that, or if there's a death of a family member, that can be obviously very stressful for the child, but if they have other family members who support them through it, they hopefully won't suffer long-term effects. The stress that we're most concerned about is the toxic stress, and this is frequent, prolonged activation of the body's stress management system. And it's been described as like revving a car engine all the time, and it just wears and tears on the child's brain and their physical health. So the brain is the most important organ in the body, of course, neurologists think, and it is very important for perceiving stress. So these factors have an effect on stress, but genetics and development and experience also have an effect. But what happens is when you have the physiologic response, your brain and body try to help you adapt. And so this is allostasis is the homeostasis that you try to achieve when you're under stress. But if it continues to occur, McEwen has written a lot about this, and he calls it your allostatic load. And it reaches the point, if you can't deal with it and you're having so much stress that it starts to have the harmful effects. So just to look at the physiology of stress, a stressful event happens, and this is the physiologic response. You have increased heart rate or other stressful things, and then you gradually have recovery from that. This is repeated stress. What usually, and we hope happens, is the physiologic response to the stress is that you adapt to it and do not experience as the stressful response every time you're exposed to the event. But if you don't, then you each time trigger this response. Sometimes you can't shut things off, and so you stay in the heightened stressful condition. And so this is might be manifested as the child constantly being afraid something's going to happen. Their heart rate's always racing. Then over time, you can actually, if you have enough stress, then you don't even respond like you normally would. And what happens in this case is that you may have more inflammation in your body because you are not having the hormones from like cortisol suppressing the immune response. So people can actually develop other medical problems from not having enough cortisol generated. So the hormonal systems that we think about in stress, there's the sympathetic adrenal medullary system, which produces epinephrine. And we all know epinephrine is essential to survival. If you're in a stressful situation, the fight or flight response is needed. But there's also the hypothalamic pituitary adrenocortical system, and that's where cortisol is produced. And when it's produced, then it mobilizes energy stores, enhances memory, activates immune response. It's this failure to cut off the cortisol that can result in a lot of potential medical and psychological and physical side effects. Stress also has an effect on our genetic function, and it has epigenetic effects also. So there's an effect on the glucocorticoid receptor hormone associated with stress. The glucocorticoid receptor it's in the cytoplasm right next to the nuclear membrane. So when cortisol is released, it binds to the complex and it moves into the nucleus. And once in the nucleus, it regulates transcription. So it can have a direct effect on genes at that point. There's also an effect that can be seen on neurotropic receptor genes, which are involved in the architecture of the brain. Myelin basic protein can be affected. And these genes are involved in, of course, creating the myelin and helping with synapse formation. There are other transcription factors that have been found to be affected with stress, the homeobox protein and RE1 silencing transcription factor. The neuron restrictive silencer factor is one that's just been recognized in the last few years. And when there's stress, it actually will reduce neuronal function, including synapse formation and maintenance of membrane integrity. But if you can block this, it will rescue the hippocampus. And so this is a schematic of it. So when you have stress, it will increase the levels of the neuron restrictive silencing factor and results then in stunning neuronal structure. And this impairs memory. And so blocking this can help prevent those effects. The epigenetic factors that have been associated with stress include changes in methylation, histone modification, and then there can be also alterations in non-coding DNA. In rats, when they subjected them to stress, there were changes in the methylation of the brain-derived neurotropic factor, and this actually persisted into adulthood in the rats, so that they had changes in the prefrontal lobe and the genes for the brain-derived neurotropic factor. There's also a correlation in humans between the severity of childhood trauma and the methylation of the BDNF promoter. Other hormonal systems and neurotransmitter systems are affected epigenetically when there is stress, including the oxytocin, which is important for establishing relationships and bonding and all, and that's affected, as well as serotonergic, dopaminergic, GABAergic, and these can be long-term sequelae of ACEs. We know that the brain develops sequentially, and understanding this helps understand why particular times of stressful experiences affect certain function of the brain. So this is just a schematic showing some of the areas of the brain that we know how they develop. Cells start increasing even before birth, and there's migration. This is the auditory and visual system, and the peak neurogenesis is within the first few months, and then it drops to adult levels with pruning, and the receptive language and expressive language is later, but again, within a few years, it's down to adult levels. Interestingly, higher cognitive functions and the prefrontal cortex specifically have a much longer period of development, and it's not until the late teenage years that the adult levels of cells are reached. So looking at different parts of the brain that could be affected by stress, the hippocampus is a target organ because it's a limbic structure, and it has a lot of glucocorticoid receptors. And it is highly susceptible then from damage from excessive levels of cortisol that would be secreted when you're under a stressful situation. And in rat studies, they have shown that exposure to glucocorticoids causes atrophy in the pyramidal cells in the cornu-amynus and suppression of neurogenesis in the dentate gyrus. So if you don't remember your neuroanatomy, since it's probably been a while since we've thought about it, so it's particularly the C3 area that is affected, as well as neurogenesis in the dentate gyrus. Studies that have looked at adults who have suffered adverse childhood experiences, and then they've actually measured what their hippocampi look like. There was a review in 2016 that looked at 37 studies that had evaluated hippocampal volumes, and 30 of those reported one or more significant difference between the control group, and some even showed that the more adversity that someone had suffered in childhood, the smaller the volume of the hippocampi. There were 3 studies that showed reduction, but it didn't reach significance. Interestingly, 3 studies that looked at only female subjects did not find significant changes in the hippocampi. And that suggested that the female may be less vulnerable. However, when they looked at more studies, they found that even in the female studies, 12 of the 15 did have reductions in hippocampal volume, but it didn't reach significance. And so it's felt that maybe estrogen has a protective effect and makes females less likely to show smaller hippocampi, but it doesn't necessarily mean that they're immune from those responses, since 12 of the 15 did show smaller volumes. When children have been looked at, 9 of 16 studies showed no significant difference. But one thing that was really interesting in looking at the studies is that the age that the study looked at the hippocampal volume, if there was no reduction, the average age was 11.3. But the average age in those who did have a significant reduction was 12.7 years. So it's felt that there may be a period between exposure to maltreatment and then it may take a while before you actually see the structural changes in the hippocampi. And retrospective studies have provided information on potential sensitive periods. Sexual abuse seems to affect the hippocampal volume if it's at 3 to 5 years of age, and to a lesser degree, 11 to 13 years. Attachment and emotional abuse, it seems to affect the hippocampi at 7 and at 14 years of age. And then early separation stress has greater effects on the hippocampus and prefrontal cortex in younger patients, but in adolescents, it seems it's more in the prefrontal cortex. The amygdala also is a key limbic structure. It's involved in encoding implicit emotional memories and in detecting and responding to salient stimuli such as facial expressions and potential threats. And there are also high density glucocorticoid receptors in the pyramidal cells in the amygdala. The amygdala has rapid growth early in infancy, and then it is fairly stable till it reaches its peak volume between 9 and 11 years, and then there's gradual pruning. And so stress actually can affect, because there's growth over a long period of time, stress can have an effect on the amygdala at many different times. Some of the studies that have looked at that have shown significant reduction in amygdala volumes. Some showed no significant difference. The 4 studies which showed a significant increase is really interesting. These were children that were raised in institutions or had mothers who were severely depressed. And so this was something from very early, and they showed a significant increase. Just like in the hippocampus, it probably makes a difference in when you do the study looking at the amygdala, because the volume of the amygdala on the MRI at 12.6 years was greater than the follow-up at 3.8 years later. So there's probably slow loss of volume following the stress that you have in childhood. Prefrontal cortex, as we showed earlier, has a protracted course of development, and it's also highly sensitive to stress. There's can be reduction in the orbitofrontal cortex in children who've been exposed to physical trauma as well as emotional neglect. And then the superior frontal gyrus can be affected with physical maltreatment. And the structural alteration in the anterior cingulate gyrus, which helps connect the medial frontal lobes and the limbic system, has been shown to be altered in adults who had suffered childhood trauma. So just to schematically show what happens with stress, the hippocampus shows atrophy over time. The prefrontal cortex shows atrophy. The amygdala may actually show an increase, but then there's later atrophy. Cerebellum has been studied much less, and we don't think so much about the cerebellum, but it has a high density of glucocorticoid receptors also, and this has been shown in rats as well as non-human primates. In human studies, where they've actually looked at volumes of the cerebellum, 8 of 10 studies showed that there was either vermis or the hemispheres of the cerebellum smaller after adverse experiences. We don't know the correlation necessarily clinically, but certainly abnormal verbal volumes have been reported in children who have autism and people who have schizophrenia, depression, ADHD, but there have not been good studies showing in children who've experienced ACEs and have smaller cerebellar volumes, whether there's a correlation with one of these clinical findings. I think some of the most interesting studies have looked at the type of childhood experience that was traumatic, and then the area of the brain that was affected. And so we talked about some of the areas, but there are other areas that have been very specifically impacted by a particular type of abuse. So with parental verbal abuse, it has affected the size of the arcuate fasciculus, and that connects the Wernicke's and Broca's area of the brain. So that is with a child's processing of the verbal abuse, it's affecting their language connections. Witnessing domestic violence affects the inferior longitudinal fasciculus, and that's involved in vision. And so witnessing the visual response with domestic violence affects that. It can also affect the visual cortex. I think one of the most interesting one was exposure to sexual abuse was associated with somatosensory genital field thinning. And then the lingular gyrus is with vision also. So it's postulated that children who've been exposed to sexual abuse may have thinning in this area as a way to help them cope with this. And so that area is smaller, and it's an adaptive thing. Exposure to maltreatment also has been shown to affect the corpus callosum more in boys than girls. As far as health effects, we're going to briefly talk about those. As you can imagine, when you have increased cortisol, you're going to have a higher heart rate, higher cortisol levels when they've measured them in saliva. There's higher dopamine levels in urine. There can also be effects on children's growth. And so a study looked at children whose mothers were suffering domestic violence, and they compared their weights and with a control group. And in the children whose mothers the violence stopped, they showed an increase in weight compared to the children who were still exposed to violence for a longer period of time. And then one of the other studies that actually looked at height showed that there was more likely to be short stature at age 7 in boys who had been exposed to ACEs. One study, there was catch-up growth, but the boys were still smaller than was predicted. Adversity has also been associated with numerous somatic complaints, which is really not surprising. Nausea, children complaining of headaches, stomach aches, dizziness. There's been an increased association with asthma, or even hospitalization for respiratory illnesses other than asthma. Parental separation, divorce, neglect, physical and abuse were associated with a higher risk of obesity. And neglect and maltreatment associated with late menarche. So there are multiple effects physically, as well as the neurologic things that we've talked about. There have been studies that have looked at developmental outcome. Children that were adopted earlier fared significantly better than those that were adopted later in life, and early poverty has also been more predictive of cognitive outcome than poverty in middle or late childhood. So looking at all of these different studies, it seems that exposure earlier in life does have really negative effects. Physical abuse, psychological maltreatment, and neglect from birth to 24 months was associated with reduced cognitive scores. I'm going to go ahead and go to some of the ones that have looked at specific measures of different learning issues and IQ. So child abuse has been associated with lower IQ, and that's been shown in a lot of studies, but there are some prospective studies that have been very controlled and very good at looking at what happens with IQ. And especially neglect has predicted impaired IQ in both adolescence and adulthood. This is a study that was one of the prospective studies that was done. They did the Bailey at 24 months, the WPPSI and the WISC later. But what you can see is that the children who had no exposure to adversity had fairly normal and consistent IQ scores. If they had exposure during infancy to adversity, their scores are much less, and even though there was some improvement, it was much lower than the controls. If they had it only adversity in preschool time, less effect, but still less lower IQs than the controls. And exposure that was in infancy and preschool, again, lower. So it seems that infancy is a particularly vulnerable time for cognitive development. And the sad thing is, even though the adversity can stop, it seems to at least persist until 8 years of age. Memory has been studied, and there seems to be some association with visual episodic memory. So that would be asking somebody to look at something visually and then recall it later and draw it. And so some of the other studies have shown some changes in memory, but it seems to be mainly related to IQ. Academic achievement, looking at achievement tests and grades in classes, have shown that physically abused children had difficulty with their reading achievement, but less so for math. And children that suffered early abuse, when they looked at their overall academic performance in first grade, had lower scores. Verbal comprehension, some changes with that, but again, a lot of it seemed to be explained by the lower IQ. Executive function does seem to be affected. And when you think about where the control for executive function is, it's in the prefrontal frontal area. And so we know that that's an area that's affected by stress. And so it's not surprising that the studies have shown that there are problems with executive function, and it persists into adulthood. So children with executive function difficulties will have difficulty controlling their behavior. They can have attention deficit disorder. So this has been correlated significantly with adversity. Processing speed, again, seems to be related a lot to IQ effects. And perceptual reasoning, I'll just go to the chart here, and this shows the different forms of abuse, and then the effects it can have on the different areas of cognitive and learning. There's psychological consequences. As you might expect, a child who's been abused, they're going to have heightened attention toward threatening stimuli. They have a risk of developing depression, post-traumatic stress disorder, borderline personality, and substance abuse. It's interesting that depression is often after exposure to emotional abuse, and substance abuse occurs after physical abuse. Sexual abuse before age 12 was associated with a greater risk of depression, but after 12 years, it was associated with severe post-traumatic stress disorder. The patients who have ACEs and then develop a mental disorder often don't respond to the same medications that somebody who has depression that was not exposed to ACEs. So there are often more difficulties in trying to treat these patients. One of the most interesting things is that it seems that adversity can go from one generation to another. And this has been looked at, looking at telomere length. And telomeres, as you recall, are at the end of the chromosomes. They're the repeats that get shorter as the chromosome ages. And children who've been exposed to early life adversity can have shorter telomeres. One of the most interesting things, though, was looking at mothers who had had abuse. They then had children. These children had not been exposed to abuse or adversity, and their telomere length was shorter at 4, 12, and 18 months, even though they hadn't been exposed themselves. So it was passed on to the child from the mother. There are other intergenerational effects that have become apparent with ACEs. Studies have looked at the volume of the brain in children who are born to mothers that have suffered adversity many years earlier. But when the children were born, they had significantly smaller intracranial volume, so smaller brain volume, and it seemed to be affecting more the gray matter compared to those children who had mothers that had not suffered adversity. A wide variety of areas showed decreased volume. Interestingly, there were no changes in the hippocampus or amygdala in these newborns, but over time, it'll be interesting to see if that more studies in the future show that the children do have volumes that reduce in those areas. Having a father who has had abuse also can have an effect on development. So as the number of maternal and paternal ACEs increased, there was corresponding significant increases in the risk for developmental delay in the child, even though the child had not suffered ACEs, having parents who had. As you might expect, maternal childhood trauma can also cause psychopathology in the offspring. And there are probably a lot of reasons for this. The mother who's had trauma herself is probably less likely to be a sensitive parent. And so there probably are many factors that contribute to this. But it is concerning when you already have one generation affected that you're going to have another generation experience sequelae of what the mother's been through. The CDC has, which is the Center for Disease Control in the US, has looked at the effect of ACEs and projected if we could control ACEs that we could decrease depressive disorder by 44%, variety of different health conditions They looked at health risk behaviors and felt that smoking and drinking would both be decreased significantly if we controlled ACEs, even unemployment and education. And these are strategies that have been suggested, strengthening economic supports for family, promoting social norms that protect against violence and adversity, trying to ensure that there are resources available so that a child has a strong start from early in life. And if we are aware that a mother's suffered ACEs, then it would be very important to make sure that these children have the resources available. In older children, we want to connect them to caring adults, get them involved in activities where they can get support if they don't necessarily get it from their parents, other adults that can step in and help them. And of course, we want to intervene to lessen immediate harm. So if a child's in a situation where there's domestic violence, or you know that there's neglect going on, you have to intervene at that point. But you also, knowing that there can be long-term effects, want to try to get them as many resources as we can. So it's important in pediatric medical settings to screen for early detection and to talk to parents about the effects and let them know that if they suffered ACEs, that can have an impact on their child. And you want to talk to them about the importance of having a supportive relationship for the child, other healthy things, sleep, nutrition, exercise, and referring them for additional services if the child has significant mental health issues or they need other kinds of care. So the conclusions that we can draw from the studies that have been done is that childhood abuse has been repeatedly associated with alterations in brain function and the structure of the brain. The type of maltreatment matters. The age that the child is exposed to the maltreatment matters. It's more difficult to figure out because of the different areas of brain that are affected and the times that studies are done, what the temporal association is between exposure and the brain changes. We know there are differences in gender responses. We don't know as much as we would like about how you can reverse the potential changes that can occur from maltreatment. And I think that's where we need to focus in the future, is what we can do to try to prevent things that we know have the potential to happen after adversity. But we still don't know about the relationship between abuse, the changes structurally you see in the brain, and what actually happens clinically. It's not a one-to-one relationship. And so the reversibility of this and the relationships between these is more difficult, and certainly a focus that we need to have for the future. So that is the end of my talk, and I'm happy to answer any questions.
Lovely. Thank you, Sarah. Brilliant talk.
Okay.
And no questions on the chat pane. So if anyone has any questions, just unmask themselves. Or if you're too shy, just type it onto the chat. Can I ask a question? So if you have a baby who's already compromised with, exposures to substances, known problems in utero, what can we do to preempt these problems?
I think the things that we talked about at the end, trying to get them the resources. And I mean, obviously these people often live in areas that don't have as many resources, so that's another strike against them too. But trying to provide nursing visits or somebody that can check on the family and try to get them the resources they have. And it can be anything from financial support, because often they're exposed to poverty too. And so that can negatively impact them. So a variety of resources, but trying to get them arranged can be challenging.
Definitely, we hear you. So you've got a couple of questions now popping up on the chat pane from Gayatri in Western Australia. Gayatri, if you want to ask Sarah your questions, you've got a double-headed question here. She's too shy. So anything about
hi, sorry.
there you go.
Hi, Sarah. Thank you. That's a very lovely, brilliant talk. I'm a neonatologist, and we look after the really vulnerable preterm infants and a lot of vulnerable families with a lot of social difficulties as well. So specifically, my question, similar to Julie, was if you have come across any studies which, of course, preterm brain is very vulnerable, we already know, but does this increase their vulnerability, particularly if they have been exposed to alcohol or drugs antenatally?
I'm trying to remember specific studies looking at, I don't recall, but that doesn't mean there are so many studies now available, but I mean, we already know that children that have exposures prenatally do have, at least clinically, I'm not sure we've looked at the brains and done the studies to show what's happened in the brain, but we know clinically that there are effects from these exposures.
So they've got a double whammy, right?
Yeah. Thanks, Sarah.
Thanks, Gayatri. And then from Sue, from Children's Court in New South Wales, any comment on prenatal violence or parental PTSD and cognitive development?
Yeah, certainly.
Put things together. The prenatal violence one, I think people talk about, but there's no kind of differentiation of that from other kind of adverse events.
I have not seen a specific study that separated that out.
Yeah, no, I thought so. Yeah.
And the PTSD would
call something, right? Yeah.
Post-traumatic, yeah.
So PTSD would be, yes, if the mother's having PTSD, that's going to be a mental health issue, and that is one of the ACE factors.
But it's specifically an issue, I guess, for the hormonal impacts on the mother as well, the triggers, especially if it's been sexual abuse, to being pregnant, and then the impact later on the child, creating perhaps a very much more anxious child, even from a very early age.
Yes, that's a lot for a child to deal with because it's so many things so early in life.
And what we're seeing now, what we're hearing cases, Sue would know this, is that you have children who've been exposed to all sorts of stresses in utero, in the postnatal period, and they become very, very nice little babies, very good babies. About 2 to 3, they start having some behavioral issues, but that's normal, toddler tantrums. But then at about 5 or 6, they report really concerning symptoms. And Sue and I have spoken about it before. They report being, very sad. There are reports of children wanting to kill themselves. They're very anxious. So there is something of a trajectory there that I think we need to acknowledge, especially in children that have known exposures like prenatal drug exposures, and provide a pathway of care for them.
Yes.
Sue, do you have a comment from that? Because that's a usual pattern you see in your work, isn't it?
Yes, and the thing that worries me is that that history, the narrative of the exposure is very poorly diagnosed, very poorly recognised, because they don't think it's important, they don't ask about prenatal exposure, and then we get the children further along when the drug problems come back or some other problem, and then they're in foster care and they're difficult to care for, and by that time, perhaps the parents have somewhat gotten their act together, but the actual needs of this child have got far bigger than a parent's able to manage. So that's the dynamic that we're dealing with when we're dealing with the impacts of the ACE and prenatal experiences particularly.
Yeah, and I think there are obviously a lot of children that have exposures during the pregnancy, but there's not a positive drug screen at birth. And so mom's not going to voluntarily tell you that. She might not get to take the child home. So
Yeah. Well, I've had a couple who've been picked up by the police, and so the drug screen was there. So it wasn't able to be denied, but then that fact was not then considered by the health people. It wasn't even acknowledged. It was known in the system, but not acknowledged as something that needed to be recognized and you know, some kind of interventions designed.
Okie dokies, we've got one from Jackie Stack. Jackie's the neonatologist from Liverpool. Jackie, did I ask your question? I'm not sure what you mean.
Oh, yeah. If you can hear me, I can talk. Yeah, I was just thinking that, you know, the parental experience of having a baby in a NICU is a very adverse.
Oh, right. Okay.
They come out of it with PTSD, and I'm just wondering if there's anyone or anyone knows of any research looking at subsequent children who may have been born at term, but nevertheless have been born to these parents who are suffering PTSD from that birth of that premature child. Do we know? Is there anything that talks about subsequent children and the adverse effect that it may have on their development of you know, being the next child along from a premature baby?
wow, that is a great question. I have not seen anything in the literature, but again, I haven't specifically looked at that. But thinking about it, you would think that it would have an effect.
Scary, isn't it?
I think we should do a study, Jackie, because we are a potpourri, a petri dish of stress in our ICUs.
Oh God, yes. And that's just the staff. Yeah.
Oh my goodness. We've got I don't know whether you're still online, Christina and Marissa. They're from our Ministry of Health. What oh yes, they still are. Christina and Marissa. Have you got any comments on Sarah's talk about how we can look after our babies who have been born to known stressors? Oh, they're all too shy.
Hi, Julie. I'm not sure if.
Yes, we can hear you. Welcome back. Yes, welcome back.
Thank you. One question I had was around, is there any protective factors that have been identified in the research? Anything kind of separate from the stresses that have been found to help kind of insulate, at least somewhat, the children from those symptoms? And thanks for the talk. It's very interesting.
I'm not sure there are great studies that have looked at that, because it's kind of hard to figure out how much you reversed, because you'd have to have such a large study and offer some supports to some and maybe not as much support to others. So but there are certainly children that they have seen, you know, them experiencing these effects, and they've placed them in programs to work on their behaviors or a very supportive environment. So those kinds of things have been helpful, but how much it changed from the child who didn't get any, it's been really hard to say. But supportive adults in a child's life, even if it's not the parents, can have a positive effect.
So we really need to learn about what promotes resilience, as well as, you know, just going through all the bad things that end up in bad things, right? We need to find the positive factors in all these studies. Yeah. Okie dokie. So we're up to an hour. Thank you very much, Sarah, and thank you everyone for joining in. If Sarah's okay with this recording, I'll send you the link as soon as it's brewed. And if you're happy with that, it'll be great if you could allow us to post it onto our WhatsApp chat groups.
Sure.
Thank you so much. Thank you, Sarah, and thank you, Stephen, for staying up to talk to us today.
Great. All right.
Thank you so much. All right. Bye. Take care. Bye.